given the current budget pressures. Thank you.
Thank you.
Thank you. I'll bring in Gordon now.
Thank you, Chair. Just a question and a comment. 4.8 talks about interim care beds only being funded in this financial year. I just wondered what the process was around future planning and that decision that needs to be made about future provision. So obviously there are financial implications, but obviously service implications there as well, depending which way that decision goes. The more general comment I had was around the overall financial position that we, like many other IJBs, are in. And we are looking towards break even on the basis of using reserves and lots of kind of short-term or one-off non-recurring funding sources. That's clearly fine this year, but by definition those won't be available next year and in future years. So I think we do as a board need to remember that while we might reach break even on the integrated budget this year, that to some extent masks a longer term trend, which is not a good financial position, and we will have to deal with that come looking at next year's budget and beyond.
Thanks, Gordon. I don't know if that's a mixture of Stephen and Patricia on that one.
Yes, thank you, Chair. So the interim care beds, first of all, I think it's probably helpful just to explain that the funding for the interim care beds was actually initially released from Scottish Government, not this financial year, but previously, and we have been using that funding as required or as needed, and we carried forward over £1 million into the current year. So that funding will do us through to the end of this financial year, but it doesn't change your question, Gordon, what are our future plans, and that's highlighted in the report too. I don't know if it would be cheeky to ask Gail to come in here to discuss the because I've not prompted Gail at all, but Gail has been working on our sort of not just our interim care beds, but actually our overall bed base requirements moving forward. So Gail, would you mind answering that one, and then I'll come back on the sort of overall non-recurrent finance one?
Yes, of course. Yeah, so there are a number of different types of bedded care, as Stephen said. So we have our community hospital beds, we have our long-term care beds, both in-house and commissioned. We have our intermediate beds, so those are people who require to be in a bedded care environment while they undertake rehabilitation. So we have those in Summerford House and Cunningham while it's undergoing its transition, and we have interim beds, and those are beds that we spot purchase from provider care homes to allow for people to come out of hospital to finish their assessment to determine their long-term care needs. Usually people who would go into interim beds are possibly heading in a trajectory requiring permanent long-term care, but not always. We also currently use them for people who require some works to be undertaken in their housing before they go home. So we have a bed-based review group ongoing. We're currently expanding the scope of that to include our housing with care as well, as another option to look at what is the current and potential future demand, to make sure we have plans in place, albeit we won't necessarily be able to progress with all the plans all at once. So that will come back to IJB in due course. There are plans in place at the moment, and ideally we would reduce and minimise the use of interim beds, albeit it's obviously much more appropriate to assess somebody for their long-term care needs, not in an acute hospital. So, for example, in relation to people who are waiting for housing works, we are in discussions with the council around alternative provision, because some people don't necessarily need care provision, but they do need suitable housing. So in terms of how we can provide that in an interim basis while the works are ongoing to their own homes. So there is a lot of work ongoing at the moment that will seek to minimise the need for the interim beds. But at the moment, in terms of the number of people who are going into hospital that do require assessment, we do need those beds, and we anticipate we will continue to need those beds over the winter period. But we will bring back a comprehensive report to IJB once we've progressed the review to a greater degree.
Thank you, Gail.
Thank you, Gail. in response to your other point, Gordon, about the use of non-recurring solutions this year, I share your concerns that we are using non-recurring solutions. We always knew that was going to be the case this year. Certainly in the business case where we looked at the budget for the current year, we've planned to spend £2.829 million of non-recurring funds, and that was to buy us more time so we can actually look at our longer term solutions. So part of the work that Gail has just discussed or outlined around looking at our bed model, that's part of the work that we're doing with our review of our care at home services and the new contract. These are all looking at our services so that we can plan on a more cohesive basis our sort of longer term strategy linked in with our strategic plan. The doom and gloom side is there is a £2.829 million. The medium-term financial plan identified a gap of just under £2 million additional in each of the following years. So we know we have significant challenges to plan for. The positive side is that since writing this report, we had a board development session in August where finance was a focus. We've had a session with our extended management team in September, where again, savings and finance and a review of our services were all core elements. So we are working and we're building on the business case. The first draft of that for next financial year will come to the next committee. And there is, I'm sure, significant work to be done because you're absolutely correct, Gordon, that there are non-recurring savings in the system just now and we need a sustainable recurring balance as we move forward. I hope that answers your question.
Thank you, Stephen. I'll bring in Margot now.
Right, my question relates to the earlier questions on prescribing. Obviously, as the service user representative on the board, I'm very anxious that none of the savings would be to the detriment of people's conditions. But my specific question, which I think maybe David could answer, is that if we did go ahead with further discussions on this, we involve patients too, because I think we must give patients responsibility in this area to look at alternatives. And I even wondered if when doctors do their review of medication, if they bring the patients in to this process as well, because I think at the moment it is done remotely. I may be wrong, but I just wondered if there's more we can do to save money involving patient participation, I suppose you would say. Thank you.
Thanks, Margot. David, I don't know if you want to come in on that around primary care.
Yeah, certainly could, Margot. I mean, undoubtedly, a one-to-one review of someone's medication done with the patient in front of you is the most valuable. But we have to remember that that would be a significant clinical commitment for pharmacists or for GPs or whoever else to undertake. And I think at the moment there really isn't the capacity to do that. So while I think that is the gold standard for a medication review, I really don't see the additional capacity within our system to actually do that. So I certainly agree with your point, but I don't think we have the solution for that. Thanks.
Thank you.
Thanks, Margot. Do you have any more questions?
Not really. I do see the logic of all that, but I just obviously feel people are much more responsible perhaps than you give them credit for as patients. Some are not, but I think they should be involved in any decisions about prescribing in primary care. Thank you.
Thanks, Margot. And I think if we're looking towards a deep dive further discussion around pharmacy, I think that's something that we can incorporate into it. Sure. So make sure that we don't lose that point. I agree with you completely. I'm going to bring Jim in now.
Thank you, Chair. Yep. As I've mentioned before, in a past life, this is prescribing and formularies has been my sort of bread and butter, working with pharmacists and GPs. It's quite a complex issue. We all know that, but clearly it's an issue that has to be addressed, and the deep dive would help. I think part of the problem is that we don't exactly know, I'm sure, where the issues are. And I think I raised this before, one of the things that would be good, and it's not about blaming people or blaming any particular practice, but within our area, we should be able to sit down privately and know which practices are costing more money, because they can't all be doing, costing more exactly. The other thing which Patricia mentioned is formulary. I think this needs to be re-looked at for a simple reason, is that, and I'm sure David will agree, is that it used to be that generics and branded generics were the cheapest things on the market, but sometimes that's not always the case. Sometimes these products get hiked up in price and the brands are actually cheaper. So I think there's an area of scope there to maybe look at that and say, look, where are these products that we're using? And it's not about necessarily changing the formulary, it's about obviously informing the GPs and pharmacists if necessary, which products, in other words, it's been light on our feet to adjust to that so that we can make savings there. I do have a suggestion that came from another pharmacist, which I won't raise today, but I'm happy to raise either with yourself, Chair, and David at another time, with one small suggestion to save some money. The other thing is, for practices or GPs that either prescribe not the wrong product, but products not in the formulary, or over-prescribed products, what are the penalties the practice faces, not the GP? I mean, I've worked with other areas, the health boards in the past, and they have introduced penalties for people that want to prescribe their favourite product rather than stick to formularies. There's quite a range of things, but I think there's more we can discuss, and I think it's an area, because of the high value, we need to tackle sooner rather than later. And I do recognise what Margaret said about involvement of patients. They need some education and guidance as well, because we all get packets of medicines with different names on the packets, and that can often confuse. Thank you, Chair.
I think we can certainly bring some of those discussions to that deep dive, and certainly I recognise what both yourself and Margot and David said around medication reviews and supporting patients to be able to swap products, for example, if another one is available in the market, that would do the job as well. So I recognise that as an individual. So I think we'll bring that all into the discussion around pharmacy when we have that. I think that would be the best. Bring it all into one place.
Yeah, I think thank you, Fiona. I think as well about changing products, bear in mind it's not changing the product because the active ingredient's the same, it's just changing the name on the packet. I don't want to worry anybody that's listening to this live stream thinking we're going to give them a different product rather than what they're currently on. Yeah, but no, thank you. That's very reassuring. Thank you.
Yes, my choice of words probably the wrong one. Changing the name of the product. So I'll bring Robert in now.
Thanks, Chair. My question's around the link between high agency spend and vacancies, and what we're doing to fill the vacancies to bring agency spend down, bearing in mind that'll have an impact on our absence figures as well, because people can feel demoralised if they're perceived to be either short-staffed or the skill mix isn't correct. So I'm just wondering what our vacancy campaign would be, or to fill the vacancies, rather than rely on agency staff. Thanks.
Patricia?
Thank you, Robert. It's a point well made, and members of the board will have been aware of our recent recruitment campaign, which on one level has been very successful, but actually we're barely washing our face in terms of those retiring and leaving and those that are starting. So it is an ongoing problem. We are doing some quite targeted work in sectors of our workforce, really looking at making sure that the staff establishment is right, so that we've got a number of vacant posts that we're looking to see that we've got the right establishment of permanent people within those areas, that we're not relying on agency in the absence of those permanent posts being filled. You'll be aware in the NHS about the detailed work that the Executive Nurse Director is leading around specific agency spend, which is having some impact across the nursing workforce and other workforces. So it's something that we're quite vigilant around, but really critically making sure that we have got the right staff in the right place to cover the services that are needed. And that's been highlighted by where the agency spend is happening. So our locality managers and others are doing quite a focused piece of work on that at the moment. Thank you.
Thank you.
Thanks. Are there any further questions? I have one which is around our savings, and we've got two around the review of housing with care service and the review of daycare services. And I'm presuming, I know that we've had some discussion around older adult daycare services. So I suppose it was just to get a bit of an idea of where we are and in terms of timescale in relation to those two items.
Perhaps Gail or Martin could answer that. Thanks.
I can comment on that. Actually, the progress in relation to the day opportunities work for older adults was halted, I suppose, because of the pandemic. You may recall recently we brought forward a recommendation to look at our opportunities for younger adults and to do that work jointly. So we are in the process of establishing a board to look at the development of that whole independence and inclusion programme and bringing on board some of the learning that we had specifically in relation to learning disabilities with the joint work with iHub and a number of other local authorities that were looking at, I guess, real new models of community integration, but actually that opened up opportunities for a wide range of people within communities as an alternative to buildings-based day services. If I remember rightly, the savings attached to day opportunities were actually historic savings, so they're not new savings, but they had halted as a result of the pandemic. There are no new savings attached to those proposals. It's just we need to realise the historic savings. We are hopeful that actually the new models that we bring forward will actually see a much broadened offer of day opportunities for people within the community, but we have just begun a really focused bit of work to take that forward. It's unfortunate it has been delayed by about 2 or 3 years, but you will get updates at future boards in relation to the progress of that, though.
Thank you, Martin, and I look forward to hearing more about that. So I will just take us back to the recommendations then. And I'll just go to 2.1 and 2.2 because they are approvals. We're happy to approve the breakdown of payments in 2.1 and approve the mainstreaming of the development fund budgets noted in section 5.4. Got some thank you, Anne. And I'll move us on to our next report, which is Stephen again on the strategic risk register.
Okay, thank you, Chair. So agenda item 7 is the strategic risk register. The register is reviewed quarterly by the audit committee and twice each year by the IGIB board. It's also reviewed regularly through the management, through the senior leadership team, and I have a regular review of that also. The current strategic risk register was presented to the IGIB committee just a couple of weeks ago, back on the 15th of September. No new risks have been added to the register since this current version was, since the previous version that was presented to the audit committee on the 16th of June. Following deep dive reviews of strategic risk 9, which was primary care sustainability, and 10, which was the non-delivery of the Scottish GMS contract, risk 10 has been downgraded to an organisational risk. So currently there are 9 live risks recorded on the register. 1 is considered to be very high risk, 7 are considered as high risk, and 1 as medium risk. I'll just jump straight to section 4. 4.1, really the summary in there is very much similar to the executive summary. The only additional item that's in there is it also makes reference to the deep dive that was undertaken on strategic risk 1, financial sustainability. The table under section 4.1 is a summary of our strategic risk register of the 9 risks and their current rating, with a note on where anything has changed since the previous review. The detailed risk register that underpins this table can be found in Appendix 1, and that should be read in conjunction with the risk assessment scoring matrix, which can be found in Appendix 2. You will see in the strategic risk register that there's an awful lot of detail that I won't go into today. Section 4.3 really just summarises some of the points that we considered each time we've been, or the last time we've reviewed the individual risks on the risk register to come up with the current scorings, albeit that they haven't changed. There is a lot of work actually behind the scenes, understanding and looking at each risk to make sure that those ratings are still appropriate. Again, I won't touch on all the bullet points, but I will just mention the last bullet point, which is over the top of the page, just to note that there has also been further deep dive work undertaken on the health and safety risk. That doesn't feature on this report because we're looking at the strategic risks here, and health and safety was previously identified as an operational risk, and following the deep dive continues to be considered as an operational risk. That then takes us nicely on to section 5, which is the deep dive programme. 5.2 looks at the deep dive that was undertaken for the financial sustainability risk 1. The deep dive itself, the information on that starts at 5.2.7, but before that there is some context to the deep dive exercise. 5.2.1 just summarises what the risk is in terms of financial sustainability, namely that if the strategic plan and the medium-term financial plan aren't prepared on a sustainable basis, then there is a risk that the recurring cost base would exceed or could exceed future funding allocations with a resulting underlying deficit. That would impact adversely on both current and future service provision and on our ability as an IJB to deliver on the strategic priorities and vision. I think before looking at the finance deep dive, it's helpful to have some background context. That was the context that we experienced as we considered the deep dive, and 5.2.2 refers to our 2022-23 unaudited accounts financial position. That was the most up-to-date information I had at the time of drafting this report. Since then, our audited accounts have now gone to the audit committee and been approved, and that underspend of 3.412 million for the integrated budget for last year has now been confirmed and audited. So I think it's helpful to note that last year we had an underspend, and many of those drivers behind that underspend have continued into the current year, and we saw that in the finance report when it came to the savings and certainly the slippage on some of the new initiatives. Also touched on the finance report on the next point as well, that we had a funding gap of nearly £13.5 million in the current year. We had a savings programme to address that funding gap. We know that each year thereafter we expect there to be another roughly £2 million per annum of additional cost pressures that we need to manage. And the note Just 5.2.3 also just highlights the £2.829 million of non-recurring savings that we planned in the current year. It also touches on the roughly half of that savings programme was initially RAG rated as red, and that was due to capacity and recruitment challenges, particularly for the prescribing initiatives. And we saw that when we looked at the finance report just a minute ago, that we haven't yet delivered on a number of our prescribing savings. That's not to say that we can't deliver, but it's certainly been the capacity challenges to get the staffing in to allow some of those initiatives to be taken forward. In fact, some additional context, and then I'll move on to the deep dive itself, just highlighting that both Falkirk Council and NHS Forth Valley as our core funding partners also have significant financial challenges and savings delivery requirements, and that has potential knock-on consequences for ourselves. Nationally, after all IGIBs prepared their business case for the current year, we consolidated the information where other IGIBs were prepared to share their information. Most were. There was a £305 million initial gap for the current financial year that required to be met through savings and or the use of non-recurring funds. And the pressures that we see that are listed in section 5.2.5, they're fairly consistent across much of Scotland. Pressures linked to demand and demographics, pay inflationary pressures and prescribing and pressures as we've also discussed earlier. So on to the deep dive itself. For the finance deep dive, there was a meeting on the 28th of June, which I attended along with the NHS Forth Valley Risk Manager and the Partnerships Business Management Coordinator to review the controls that are in place and the controls that are required to be in place around financial sustainability. As part of that review, each control was classed as being preventative or contingent, or an assurance activity. So preventative, where the control is designed to stop the risk from happening; contingent, a control for when the risk does occur; and then assurance, where it's more to do with the monitoring and assurance to see how that risk is unfolding. Across the 9 current controls in place, 5 were deemed to be preventative, 2 were deemed to be both preventative and contingent, and 2 were classed as assurance activity. For the 6 future or further controls, 5 were preventative and contingent, and 1 was assurance activity. We then considered the criticality of each of the controls, and we found that 7 of the controls are absolutely critical, 3 are classed as very important, and 5 as important. We then reviewed the effectiveness of the controls that are in place. 6 were considered mostly effective, 2 partly effective, and 1 was not deemed to be currently effective. This was my first attempt at working on a deep dive with more experienced colleagues in this area. I wondered why we only had mostly effective and not fully effective, but it was pointed out that if any of our controls were fully effective, there wouldn't be a risk. So the best we can expect really is for our controls to be mostly effective. 5.2.12 then looked at all the different factors, the different categories that we would consider when we look at any risk, and we measured the finance risk against each of those categories, and the conclusion was that the finance risk remains high. Now that conclusion took into account our current controls, our future controls, and very importantly that financial context that was outlined in the first part of the report. And then finally 5.2.13 just notes that where any risk is considered to be high, that would mean that we would expect to review the risk monthly. If it was a medium risk, then it would perhaps be quarterly review of the risk. But for the high or very high risk, there's an expectation that we'll review them on a monthly basis. I won't go through, you're probably pleased to hear the risk 9 and 10, the deep dives in the same detail. The report format's the same, a bit of context first of all, and then detail on the deep dive itself. So I'll just bring us back to the recommendations. 2.1, consider and comment on the high-level summary of the strategic risk register that's presented at section 4.1. Consider and comment on the detailed strategic risk register that can be found in Appendix 1. And there's a bit of an error on my part with the final recommendation. It notes it's to ask the IJB to note the deep dives outlined in section 5 of the report and consider the assurance they provide to the IJB committee. Unfortunately, I copied this from the paper I used for the audit committee, so it does say audit committee there, but I would like the IJB to consider the deep dive information and whether that provides assurance to yourselves that risk is being effectively managed through the processes that are in place. Thank you, Chair.
Thank you, Stephen, and very comprehensive, and I think very useful, the deep dives into the areas of most concern, and I think that's certainly there would be things that any of us would probably think of as the things that we're most concerned around things like financial sustainability, and obviously primary care sustainability is of huge concern to not just ourselves as individuals, but our community across Falkirk as well. So I'm going to open it up for questions. And I'm seeing none. I'm seeing Anne.
Just one. Primary care sustainability is obviously a matter of concern, as you've just said. I wonder if you'd like to, perhaps David, I see he's got his hand up as well, would like to say a bit about the fact that the current situation is one of change, which in itself is likely to raise the risks up a bit. But how much is related to the current change situation and how much due to other factors?
I will bring David in a minute, but I want to probably ask Stephen in relation to the deep dive. What of the risks are related to the change and the bringing the primary care into the IJB, and what are wider risks to primary care sustainability?
The extension table and so that if it goes.
So in terms of the review that was undertaken, or the deep dive review of the primary care risks, it's probably fair to say that the review has more focused on the challenges with GP sustainability rather than the underlying infrastructure behind that. So in terms of that change between it previously being managed via the NHS board and now coming through the IJB process, it's probably more been a focus on the actual underlying issues and how we address those underlying issues, rather than anything to do with the fact that there's now a different approval route. We're certainly aware behind the scenes and are trying to progress with colleagues, because it's not just Falkirk. IJB, although we are leading, very much the responsibility for primary care continues to be both ourselves and Clacks and Stirling IJB, and I think in Patricia's report earlier it did touch on the sort of governance discussions that we're having with Clacks and Stirling, and the last meeting we had, and Patricia will correct me if I'm wrong, we agreed that we will use primary care as our example or pilot, really, to see how we actually improve and develop our governance arrangements for those services that some people may refer to as hosted or coordinated, where the responsibilities, the decision making aren't just with resting with one decision-making body, but where a number of bodies are jointly responsible for approving and agreeing a way forward. I don't know if that answers your question, Councillor Hannah, but I think what I'm really
Largely,
saying
I think
is,
so, yes.
okay, thank you.
Thanks, Anne. Can I, David?
Yeah, I mean, it wouldn't surprise you to know I'm talking about risk number 9 as well, the primary care risk. I think, as Councillor Hannah says, change always makes things happen slower, and we have seen that. I don't think it's been a massive factor. I think as always, lack of funding is probably the biggest factor, and I think it would probably surprise most people in this committee that primary care delivers over 90% of patients' health contacts in the NHS, but we actually are funded by less than 7% of NHS funding. That's a massive thing that really hinders what goes on within primary care, and that's only going to get worse. You know, the last few years have shown that's going to get worse, as Scottish Government's awards have really not been equivalent to the awards for Agenda for Change, pay rises, etc. And I think we have been quite good at identifying the risks on the risk register, the factors that are affecting primary care. I'm not sure we've come up with the solutions. So it's a frustration for me and for everyone working in primary care that we haven't been able to find the solutions, but I think we have identified a lot of the risks. I was slightly surprised that the delivery of the new GP contracts being taken off the risk register and put on a different register, because I'm sure a lot of this committee would like to know what's happening with the progress of that. We're 5 years into delivering what was meant to be a 3-year delivery programme, and some of you will have been at the presentations at the beginning where we described what you might expect, and medication reviews done by a pharmacist was one of these things that we described 5 years ago that you know really hindered a lot by funding we've not been able to deliver. But seeing a physio, seeing a mental health nurse, seeing ANP nurses, getting blood taken in a timely manner, these were all things that were promised to general practice and promised to the public 5 years ago. So, you know, I'm not sure of the rationale for downgrading it, and I wonder if the committee will still be kept up to date with what's going on with the delivery of the primary care contract if it's not on the register. Thank you.
I thank you, David. I'm just checking in 5.4.2 that it will continue to be reported. Is that a lot of the primary? I'm using primary. The main way of the assurance of the risk, that particular risk, is through NHS Forth Valley. Can you just confirm that process for us, Stephen?
So we are developing our overall risk processes, but as matters stand just now, without wanting to be too controversial, we are probably have a more developed system for our NHS risks. They are all put through a Pantana monitoring system, and so the risks that don't come here as our strategic risks are still fully monitored, fully escalated, fully reviewed through that Pantana system. Out with today's meeting, David and myself will both have attended meetings with the GP Sustainability Group, which Scott Williams chairs as the sort of clinical lead for general practice. And as part of that meeting, our colleagues from the NHS Forth Valley Risk Management Team attend, and we review regularly the full primary care risk. It's not restricted to the risks that we are seeing here today. It will be the GMS risks as well. So in terms of visibility here, where there are concerns, then of course they'll be raised here. primary care as a whole, there's an awful lot happening just now. Primary care improvement plan, there's probably a number of significant updates. I know that we recently had an update report to, or the last committee cycle on our primary care services. I'm absolutely certain that there will be future updates coming to future meetings too, for the same reasons that it is a developing area. It's an area that, as David says, there are a number of concerns just now from our GPs, and we are working with the GPs, particularly on that primary care improvement plan. We had a meeting as recently as yesterday with Scottish Government, where we were looking not just at our own local position, but nationally, and feeding into that national position in terms of how we would develop the primary care improvement plan, which was the primary sort of driver, the primary investment, if you like, for ensuring that we have a sustainable general medical service, not just here in the Forth Valley and the Falkirk area, but across Scotland.
Thanks, Stephen, and obviously we'll have read across both audit committees in the IJB and within the NHS. Patricia?
Yeah, it was just to provide a short update on the more general primary care and support for primary care, which just came over into the partnership as of the end of last month. So we've been out to advert and have a preferred candidate for the head of primary care post, and members of the board will get to meet that individual, and we will be receiving regular updates from that new head of service who will join the team. We will also be looking, as part of our due diligence, at the funding and the infrastructure and capacity and resource that there is to support primary care. There has been a huge focus on the primary care improvement plan, but we also need to extend that out into the broader primary care, and how we can, through aligning with some of our community, third sector and our own social work and social care services, how we can improve the impact through that joint working. So it's an area that I'm personally really excited about, but just to let you know that we do have additional resource, and I would expect we'll be looking at further investment into that infrastructure to support primary care. Thanks.
Thank you. So with that, are we happy to agree the recommendations?
Agreed.
And I will excuse me, I'll move us on to Martin, who'll be bringing forward the report on the Falkirk Alcohol and Drug Partnership.
Thank you, Chair. Good morning. This report really just provides an update on the work of the Alcohol and Drug Partnership over the past 12 months. I'll just highlight a couple of points within it. You will see at section 4, it provides an update and delivery of the MAT standards. Members will be aware that these medication assisted treatment standards are really setting the direction for alcohol and drug partnerships for the future in terms of access to treatment and how we deliver services. There's a table highlighted at section 4.5 which shows our current progress. The amber areas, particularly in relation to access to treatment, is looking to identify resources for same-day prescribing in terms of that medication assisted treatment. And that's probably one of our hardest challenges, because it relies on making sure that services have access to appropriate clinicians to start prescriptions on the first day that people enter services, which is a real shift in direction for services. These MAT standards are really going to design our service delivery models for the future. So it's not a case of these are kind of additional tasks for us. It's actually something that all our services are going to be aimed towards delivering to ensure that people can access treatment and stay in treatment for as long as possible, as quickly as possible. We have also highlighted, I guess, at section 5, the recommissioning of the third sector alcohol and drug treatment services. At the moment, those services across Forth Valley are delivered by CGL. That contract is about to enter the second year of its extension, and we are working jointly with Clackmannanshire and Stirling IJB to look to deliver, I guess, a commissioning consortium model for Forth Valley-wide services. So Section 5 just updates in relation to that progress. Section 7 is probably the next that I will pull out. Members may recall that probably for the last 2 years I've been really keen to review the operation of the Alcohol and Drug Partnership. Up to now, the partnership itself, in terms of the meetings, has pretty much been an information sharing forum where we've provided partners updates on national and local changes and priorities. We've discussed budgets and I guess just generally information awareness raising. I was really keen to shift that so that it actually becomes a model of scrutiny and really a driving force behind services. So the recommendations really that came through the ADP were to establish an ADP executive membership and a number of thematic subgroups that will focus on certain areas, and that's probably where the majority of members of the current ADP will sit. The idea behind the executive is it will be the real decision makers that actually hold budgets and can make decisions, and actually they will consider the input from those various subgroups. We're also really keen that actually we get real service user voice within that group. At the moment, I have to say we have representation at the ADP meetings, but it's just in terms of listening to us pretty much talking in terms of directions and the national agenda. We are really keen to shift that around so that actually the executive hears what it's like in reality from those that use our services and those that require services. In terms of the future arrangements, I suppose the IJB today will be asked to continue with my term of chairing the ADP. You may recall it was due to end last year, and at that point we asked for a 12-month extension until we had progressed to the new arrangements. Unfortunately, whilst we've agreed the new arrangements, we are still waiting on a number of organisations putting forward members for the new executive. And we presented a paper to the Chief Officer Group, I think it was about 2 weeks ago, and asked for nominations from the statutory partners to become members of the ADP executive. And we hope that that will be concluded by December. So an ask for the IJB today is to agree my extension as chair until such time as we're able to bring back a nomination for an alternative chair, which I would hope to be able to do at the December committee. Section 8 highlights the drug related deaths information. I suppose one thing to highlight is there has been a significant reduction, or there was a significant reduction in the period covering 2022 compared to the previous 5 years, a fairly significant reduction. However, it's worth highlighting that numbers of drug-related deaths are still extremely high compared to where they were maybe 20 years ago. And the fact that we've had 23 drug-related deaths in the year 2022 is still really a horrific actually number. The hope is that the MAT standards and that quick access to treatment, those alternative models that will actually keep people in treatment for as long as they view the required treatment, will hopefully lower that number further, but there is still significant work to be done. I'm joined today by Phil, the ADP coordinator, and together we'd be happy to take any questions. But in terms of the IJB recommendations, you're asked to note the activity of the ADP over the past 12 months and note progress towards identifying the executive members and agree the chairing recommendations up until December. Happy to take any questions. Thanks.
Thank you, Martin, and I'm going to open up for questions, and Anne.
Thank you, Fiona. Thank you for this report, and you've obviously been very busy on the ADP. Just wanted to focus in a bit on the drug misuse deaths, which obviously it is welcome that we have seen a reduction in the death rate. But I wondered if you had been able to have any kind of a dive into why that might be. One would like to think it's the excellent work of the partners that is enabling this improvement. But it would be really interesting to know your perceptions of what the reasons are for it. You think that the MAT standards might help further lower, but the question is, what has brought it to where we are now, and what are the good bits that we could perhaps build on?
Thank you, Anne. Is it yourself, Martin, or Philip?
Yeah, I'll come in initially, I think, and then I'll maybe hand over to Phil around some of the specific work that we're taking forward. I have to say, in terms of the reduction, I think we're unable to really say at this time what it really is. It requires a lot more analysis. We would hope that it was some of the great work, but actually we'll recall that data was coming at the tail end of the pandemic, so I suppose we're not sure if the pandemic changed people's behaviours, or actually if people's behaviours are actually beginning to change, or whether it's a result of some of the services that we are putting in place. We have done some, I think for me, the targeted work that we do around, I guess, prevention and raising awareness, and particularly some of the work with schools and things, I think will take some time to filter through the system. But actually, I think for me, that's probably one of the priority areas. I think by the time we find people are, I guess, in that behaviour of chaotic drug use, I think it is really difficult for us to change those behaviours. I think services allowing quicker access, if we can address matters of stigma so that actually people see it as okay to go into treatment and ask for help, will improve the situation. But I do think that early intervention focus work is really what we need to highlight actually there are alternatives for people. But I'll ask Phil to come in because he's probably got a far more informed view than me. Thanks.
Thanks, Martin. To be honest, I wish I did. It's a really good question, Councillor Hannah. And I think if we knew we could bottle it and sell it across the country, it's really difficult to know. What we've been trying to pursue back in 2020, in January 2020, the Drug Death Task Force published 6 emergency themes: targeted distribution of naloxone, implement immediate response pathways for near fatal overdoses, optimize the use of buprenorphine, target the people most at risk, optimize public health surveillance, and ensure equivalence of support for people in the criminal justice system. And they published those 6 emergency themes as a template for ADPs to follow. And I think what we've been trying to do over the past year is follow that and trust the process. And I think that if there's no one element of the work we've done that we can pinpoint and hold up to the light and say this is reducing drug-related deaths, but I think it's a combination of all the work. It's a combination of the raising the profile of the work that the ADP does, like Martin says, attacking the stigma that people feel that disallows them from accessing services, making sure that services are more visible, working together closely in partnership in areas where they're most needed. Also, investigating and really drilling down into the data and the backgrounds and the context of why people are suffering from drug-related deaths. And it's a really illuminating process, that, because it's not what you would normally expect. It's not people dying on the end of a needle in a lot of cases, as the stereotypes tell us. There's a lot of nuance around drug-related death, and I think it's working with that and engaging in a wider discussion with services out with the traditional drug and alcohol field, if you like. So talking to people in housing, in criminal justice, trying to get conversations going with the wider sector, if you like, and making the work of the ADP crucial and integral to the wider health and social care partnership offering. And I think these are all elements of the work that we're doing, and we're by no means finished. There's a huge amount of work to come forward, but I think what we're doing at the moment and what hopefully people will see is that we're building solid foundations here. We're really looking at the system, making sure it is MAC compliant, making sure that elements of the system work in partnership with others, looking at the data that we have and interrogating the data that we have in order to make sure that the next phase, if you like, is more relevant to the needs that we have specifically within Falkirk. So yeah, hope that helps.
Thank you. That's very useful. Thank you.
Thank you. Do we have any other questions or comments? If not, are we happy to approve the progress towards identifying the ADP exec membership and chairing recommendations?
Agreed.
Agreed.
Thank you. So I'm going to move us on to our next report, and I'm aware that we've got about 8 reports left. So I'm going to ask presenters to be fairly brief so that there's space for questions. I know that everyone will have read the papers anyway, so I'm going to hand over now to Martin on a care home for adults under 65 framework.
Thank you, Chair. Members may recall I highlighted this at the last IJB. It's a piece of work that we were taking forward to look to develop a framework for our care home providers for under 65-year-olds. You may recall that the last time I highlighted that although we use the Scotland Excel framework for some of those placements, the majority are placed out with the Scotland Excel framework because that only really covered adults with a learning disability and autism, I think it was, whereas it excluded a whole number of other client categories. The recommendation really is that we take forward a commissioning framework that covers multiple groups of adults under 65. So those are adults with learning disabilities, mental health issues, physical disabilities, drug and alcohol issues, and complex and challenging behaviour. I'm joined today by Nicola Morrison, who's our procurement advisor, who took forward a lot of this work and engaged with providers, actually wrote up the framework in partnership with colleagues and has written up today's report. So really she's done the bulk of the work for us to get to this position. And her colleague James King, who's our procurement coordinator, who I suppose has supported us to get to this point. I think for me it is really important that we have a framework agreement for provision of residential care for younger adults so that we can actually, I guess, be assured that those that we are contracting to provide services have the appropriate skill set and meet the appropriate requirements, and to ensure that we're providing really good quality of services within a framework that we can monitor and regularly review. The paper is extremely lengthy, but I guess for me, parts that I would highlight are the framework itself, and really, I guess for me, the paper in Appendix 2, which highlights the consultation and engagement process that has gone alongside this work and actually has been responsible for us delivering our recommendations in terms of that framework. I think I've probably said all I need to about that. I'm hoping people had an opportunity to read through the paper and the appendices. I'm happy to take any questions, but I may bring in Nicola or James, given their particular areas of expertise. So happy to take any questions. Thanks.
Thank you very much, Martin, and certainly I was going to refer to the considerable level of engagement and the comments that were broadly positive across the piece. So I'm going to open this up for questions. None? Okay. Are we happy then to approve the procurement strategy? Great. So thank you everyone for your work on that. Okay, and I'll move us on to our next report, which is the Partnership Funding Progress Report. And I believe that's
Support. So,
what happened there? Oh, yes, I'm getting ahead of myself. The Care and Support at Home Strategy Update, and that's Martin again.
Yep, me again. Thank you, Chair. This report really is just providing an update on the progress in relation to the care at home contract strategy. And we had hoped to be in a position to bring that today in a similar vein to the paper we've just had. However, we're still progressing with some work in relation to developing that framework. So this report really just highlights some of the principles behind our model and our thinking, and we would hope to bring a similar paper to the one you just had in relation to the younger adult residential to the IGB in December. So this paper just really provides an update. In terms of their principles, you will probably recall it was really designed to ensure that we undergo a full procurement exercise, we have a standardised approach to pricing, we maximise collaboration and partnership with the market, so that's ensuring that we work extremely well and closely with our external providers upon which we really rely to deliver services across Falkirk. Again, really focusing to ensure that we provide high quality accessible care that focuses on people's outcomes and really is underpinned by the health and care standards. Members may recall probably a year ago I presented a paper asking us to move to the Scotland Excel framework and hopefully include providers that weren't part of that framework for a 12-month period until we got to this stage. Unfortunately, Scotland Excel couldn't reopen their framework, so we had to enter into a number of individual contracts with a significant number of external providers. But our ambition really would be to bring the Falkirk framework live with effect from the beginning of April next year and have all our providers covered within that framework. And really, as I said, that's to ensure that we get a real focus on what we need in terms of the Falkirk citizens. So this report, as I said, it just provides an update on the work. Next month, in December, you will get a far more detailed report, which will include the framework and the service specification, but work is ongoing at this time. There's a timetable attached to Appendix 1, which really just sets out the key milestones. And as I said, we aim to be going live with the new contract on the 1st of April 2024. Happy to take any questions about this as well. Thanks.
Thank you, Martin. And I know this has been a really big piece of work, as the same as the previous agenda item. You know, they're all very meaty pieces of work, and so thank you for that. I'm going to open up for questions. Anne.
Thank you, Fiona. Thank you for the report. Yes, I think we all recognise there's a huge piece of work involved here. What I would like you to say a little more about, though, is in what way having a Falkirk specific framework is going to either increase the availability of care, or increase the quality, or increase the localisation of it, because I would be hopeful that it's more local contracts that will be successful rather than big business.
In Falkirk, we rely on a real mix of providers. So we have some national organisations providing services for our population. But actually, you're right, we also have some very small local providers. I think for me, in terms of the local provider, I have to say that the carers themselves, the vast majority live within the Falkirk area, and we are really pushing forward, I guess, fairer recruitment practices within that. So we would hope to see the staff across the sector benefit in that way. In terms of, I guess, the model itself, we are looking for that to, I guess, work in partnership with the new model for our internal service. So we are really focused, I guess, on the skills of that workforce. the consultation with the external providers is really looking at how can we develop a shared offer for people. So similar to the younger adults residential framework, we are looking at opportunities, I guess, to upskill the workforce and develop that workforce. And a big focus, I guess, for the new contract will be on quality. The existing framework that we have, and indeed the Scotland Excel framework, really operates on a balance of quality and price. The new framework that we are working to develop really focuses on quality. So I think the present model is something like 60% quality and 40% price. The new model is looking at 90% quality and 10% price. So we will really be, I guess, hopefully using providers that have excellent quality in terms of care inspectorate grading and our analysis of their work. And for me, those will be the providers that we go to as a matter of first choice. But our hope is actually that drives up the level of quality across all providers, because all providers want us to engage in business with them. So that shift from price and quality to really quality will hopefully drive up practice. And the fact that actually we're looking to engage with providers to develop not just our in-house models of care, but also theirs. There has been some talk around should we look to develop a training academy across the workforce. Now, that's something I'm really keen to look to develop alongside some of the providers. Some of them are really happy to do that and are really keen to do that. Others have their own kind of learning development teams, some of the bigger organisations. But for me, if we can work in partnership to develop that real quality improvement in terms of staff, give much more improved offers to staff in terms of, I guess, their job satisfaction, their career development, their opportunities to learn, and that commitment actually that we will work in partnership with them. For me, I think it can only improve the quality of care across the whole of Falkirk. And actually, we have already done some joint work in terms of recruitment retention. I would hope to build on those kind of things, which actually will identify that the care sector in the main, whether that's the private sector, the third sector or the statutory sector, actually can open up real opportunities for younger people to begin careers and stick with us. And my hope really is that helps us to turn around our current model, where we find a significant work profile of people, I guess, my age and above, that are probably due to retire in the next 5 to 10 years, to actually a job offer that's really attractive for people to come in and actually develop their careers. So for me, the big benefit of the new framework is it's going to be really focused on that partnership working much more than we have done in the past. And that drive on quality actually, I think, will really benefit our citizens. And hopefully that answers your question, Councillor Hannah.
That answers my question very fully. Thank you, Martin. And I look forward to seeing the report coming in December, and over a longer period, the improvements that hopefully this will bring forward.
Thank you, Anne, and thank you, Martin. Do we have any further questions? If not, obviously we'll see the update at the next IJB meeting. So thank you for those reports. I'm now going to get it is Leslie this time for the HSCP partnership report. I've managed to see my agenda correctly. So Leslie, would you like to come in?
Thank you, Chair. Good morning, everybody. So the purpose of this report is to provide the board with an update on partnership funding, highlight the ongoing review of partnership funds, and also provide an update on the Suicide Prevention Fund. So in June 2021, the IJB approved the first partnership funding investment plan. The plan presented the range of ring-fence funds available to Falkirk HSCP. Funds presented include recurring and ring-fence reserve budgets held by the HSCP and ring-fenced allocations, thematic ring-fenced allocations from the Scottish Government. An overview of the funds is presented in 3.4 Table 1 of the cover report. In terms of the benefit of having a single investment plan, this enables us to provide consistency and oversight of investment. And it means that we have the ability to respond directly to local need and also maintain a focus on early intervention and prevention. Appendix 1 of the report provides an overview of the current funds and the decision-making process associated with each. It's important to highlight that a critical aspect of each fund is the expert multi-agency commissioning groups, which gather information about local need and then make recommendations around about how the funds should be used and monitored thereafter. During 2023-24, the total value of partnership funds is a recurring budget of 3.9 million and non-recurring reserve of 6.15 million. Funds invested span a wide range of themes and target groups. The most significant investment theme is currently mental health and well-being, which is shown in the first pie chart in the Appendix 1. In terms of target groups, Figure 2 of Appendix 1 shows the most significant investment in older people, followed by unpaid carers. Over 80% of the projects or services funded are supported within the third sector. And this also means that the majority of funds are invested in local organisations. So we have 63 allocations which span Falkirk, 10 which span specific localities, and 18 that support activity within specific wards. This helps to support the community wealth building agenda. Around 75 projects and services are currently supported, ranging in size from significant investments in large local organisations such as FADAM and the Carer Centre, through to a £300 startup grant to a long COVID support group and a restart grant providing a new cooker to a local lunch club for older people. Excluding the small grants, monitoring information is collected on a quarterly basis. It's worth noting that at the time of approval of the investment plan, we also introduced a revised monitoring framework, which was co-produced with partners. This monitoring framework shifted the balance of numerical data to focus on project journey and service user outcomes. The model has proved really effective in terms of qualitative data. However, it's been acknowledged that we have there's a lack of consistency in terms of the numerical data that we're now collecting. For the main programme within Appendix 1, you'll note that the performance information provided was provided during Q4 only. This has been amended for 23-24, and we're working with partners to improve the collection of consistent data. The report also highlights that the investment plan is due for renewal by the 1st of April 2024. It's proposed that working with the expert commissioning group and all funds, form a single investment plan, and that the period covers 2024 to 27. It's worth noting that there will be variations throughout the 3-year period as funds either cease or are introduced, be it from HSCP or Scottish Government. We also note a reduction in the total value of investment made via the main programme from 2.6 million in 23-24 to 1.479 million in 24-25. This is largely due to the fact that in 23-24 investment included approximately 1.1 million of non-recurring reserves. So essentially the recurring investment will remain consistent. A detailed review of the main programme is ongoing and the outcome will be presented to SLT and then the IJB towards the end of the year. Finally, in section 5 of the report, we note a change in the use of the Suicide Prevention Fund. SLT approved a recommendation from the Expert Commissioning Group in July 23 to close the fund as a challenge fund and to use the remaining balance of approximately 75,000 for targeted commissioning in line with local need. In conclusion, the Health and Social Care Partnerships partnership funds offer the ability to establish, test, transform and accelerate integrated service in line with local priorities. The recommendations for the report are to note the content of the partnership funding annual report, approve development of a single investment plan, and note SLT approval to close the Suicide Prevention Fund as a challenge fund. Thank you very much, and I'm happy to take any questions.
Thank you very much, Leslie. And you know, the report is, when you look at the amount of groups and the amount of people who have been helped and supported from this funding, I think it is absolutely incredible and a testament to everyone who's been involved and to the groups working on the ground with individuals. So thank you for that. I'd like to open it up for any questions or comments. Ian.
Thank you, Chair. Just a comment, really. I think, as you alluded to there, Leslie and her small team undertake a huge amount of work and support funding for the third sector. So really just to voice appreciation on behalf of the sector for the work of Leslie and her team and the wider partnership in supporting small and large third sector organisations within Falkirk. So thank you, Leslie.
Thank you, Ian. Do we have any other comments or questions? Are we happy to agree the recommendations?
Agree.
Well, in that case, we're going to take, we've managed to catch up, so we're going to take a short 10-minute break, and the live stream will go off in a moment. So that will bring us back at 25 past, right, 10? Yeah, 25 past or 24 minutes past, and we will see you all there for the rest of the reports. Welcome back, everybody, and I hope you all managed to get a cup of coffee and a wee stretch your legs, and move straight into the performance monitoring report, and I can see Callum.
Thank you, Chair, and good morning, everyone. For this iteration of the performance monitoring report, we've also provided a briefing of the Improvement Services local government benchmarking framework, and I'll provide some further detail on that towards the end of my update. In terms of the regular report, performance is reported up to June 23 where possible, and with a year-on-year comparison. As normal, there's a focus on exception reporting. I won't go through every detail just now, but I'm going to take you through some of the key areas highlighted from the main report. The report highlights there were some improvements on the year-on-year position to June 23 for both the Emergency Department 4-hour compliance and delayed discharges. However, both remain areas of significant focus. The June 23 4-hour wait compliance for the Falkirk Partnership highlights a small increase in performance to 61.3% compared with 57.6% in June 22. The delayed discharges June 23 census is noted at 52 total delays, and that's compared to 73 delays at June 22. Of those 52 delays at June 23, we had 28 standard delays, 18 of which had been delayed for over 2 weeks, and there was also 24 guardianship and Code 9 delays. Of our 28 standard delays at the June census, the most common reason behind that delay was a wait for residential care. The overall position remains under continual review, and sections 3.1 and 3.2 of the report provide some further details as well as some of the actions ongoing to support these areas. In terms of sickness absence, for social work adult services, the overall sickness absence figure for the first quarter of 23-24 was 10.6% compared to 11.7% for the same period last year, so a slight reduction of 1.1%. For NHS services, the overall June 23 sickness absence position is reported as 6.4%, and that's fairly static compared with 6.2% in the previous June. The report details the latest position for waiting times for psychological therapies, and in June 23, just under 75% of a total of 347 patients started treatment within 18 weeks of referral. And that's an improvement from the previous month's position of 72.7%, but also an improvement from the previous June when it was 64.3%. The report also notes that while performance has been lower than we would like, it has been above 70% for 4 consecutive months, and that's the first time that's actually happened out with the COVID period. And just lastly on our regular indicators before we move on to the benchmarking framework, at the previous IJB we introduced a new indicator on the number of individuals assessed and waiting for a care at home package. And so just to note that further progress in this area has been made, with numbers dropping from 212 in June 22 down to 39 at the end of June 23. Appendix 3 in the full report contains a briefing from the publication of the local government benchmarking framework earlier this year. It covers some indicators we're familiar with and for a time period further in the past. However, it's a really helpful tool, and where it adds value is that it allows us to compare ourselves to both the national picture and to our peer group. In order to support interpretation of the publication, we've produced a briefing which details the indicators as well as a performance at a glance summary. The summary focuses on how we compare with the national average, and we've produced 3 categories. So the first category would be performs better than the Scotland average, so that's anything greater than 2%. 2 percentage points better than the Scotland average. We've got a similar to Scotland average where we've said anything within that 2 percentage point, and then there's a third category that doesn't compare as well, and that's anything not within 2 percentage points. So 2 indicators fell into the category of better than the national average, and that included the indicator on care inspector grades. There was 1 indicator that fell into a range similar to the national average, and that was around carers feeling supported. And there was a further 8 indicators in the category of being out with 2% of the national average, and that included indicators like around delayed discharges, for example. So hopefully the local government benchmarking framework briefing has been useful, and we're going to share that internally as well to try and encourage any learning where possible. In terms of recommendations, the board's asked to consider and comment on the content of the report and to note that appropriate actions continue to be taken to address the issues identified. Thank you very much for listening, and happy to take any questions or comments.
Thank you, Callum. I will have one question, but I'll bring in Jim.
Oh, thanks, Fiona. Thank you very much. Sorry, my camera seems to have gone dark. Apologies for that, folks, but maybe that's not a bad idea. Hide my face. Just to touch on the absence figures, it was discussed at the recent Falkirk Full Council meeting as well. The figures are horrendously high, no matter which way you look at it. There was a couple of things, mainly requests, if I may, through yourself, Fiona, is one, sickness accounts for one element of absence, but of course there are other forms of absence. I would actually like to see somewhere, you know, the percentage of other forms of absence. You know, people saying, well, my car broke down in the motorway, the dog ran off, or whatever. You know, it doesn't really matter, because that is a critical factor as well. The other thing with the actual numbers, I'm not asking for any confidential information, people's names of that, but to my mind, as a layperson, absence falls into a couple of categories, if not more. One is long-term sickness due to very serious illnesses, you know, and the other one is, you know, just general people that just, you know, they've got a cold, a flu, or whatever, and they don't turn up for work. So I would, if possible, like to see in a future report or before the next report, the number of people in that first category, the long-term instance, and what percentage that accounts for, and then the other category, because clearly anybody that's got a long-term illness, there's no way you can actually ask them to reduce that figure down, you know, if they're ill with cancer or anything else, you know. But the short-term one is where the action should really be happening. So I really would appreciate that, because I know we may well say the rest of Scotland's in line or whatever, but the figure is incredibly high. There's a cost factor, usually cost factor involved, and if 10% of your workforce isn't working, then lots of other targets and ambitions and healthcare, you know, objectives will not be met. So I hope that all makes sense, Fiona, through yourself.
Thank you, Jim. I'm actually going to bring Patricia in on this one.
Thank you, Councillor Flynn. Yep, we make strenuous attempts through our managers and our line managers to implement both the council and the NHS managing absence policies, which have a number of triggers and all involve discussions with the line manager and reporting. I can speak to HR colleagues about getting that data around long-term absence. You know, I think it's just worthy of note that we have a workforce which is an ageing workforce as well, who for some of our carers are doing quite heavy manual work and have been for a long number of years. And we need to take that into account around the occupational health and support that we provide in relation to musculoskeletal and other issues. There's also issues around stress and mental health. Both the council and the health board have occupational health services, and we have staff health and wellbeing groups that are looking at providing additional supports, which during COVID we had quite extensive offers in place for our staff, and a lot of that continues. It is a real concern at that level, and we want to encourage people to be at work and want to support people to return to work where that's appropriate for their health needs. But thank you for that, and I'll take that away as an action. Thank you.
No, thank you, Patricia. And bear in mind, through yourself, Fiona, it's not a criticism of the work that yourself and other officers are doing. Far from it. It's you know, I've been a manager in the past and managed a far more smaller team, and I understand the challenges, you know, and the ageing workforce, I accept you've mentioned that before, but I do think the numbers are out of line with, I don't know, not similar departments, but departments that, you know, road workers that do heavy work on the roads and do lots of things. But thank you. I appreciate any information you've given back to me. Thanks, Fiona.
Thank you, Jim. Can I bring in Robert?
Yeah, it's just building on Councillor Flynn's point about absence management, and we have to recognise that most of our staff, or the highest percentage of our staff, are off with stress. So tackling the causes of stress, such as I said about filling vacancies and etc., would possibly assist with our absence rates. We need to tackle the stress problem that we've got. It's in all services and it's constantly the top scorer as to the reasons for people being off. So we need to tackle the stress element of it. Thanks.
Thank you, Robert. A point well made, and I know that that's something that I know in both the partnership, the council, and in the NHS, that's an area of significant concern, and you know, particularly for those staff who were working throughout the pandemic, and in very trying circumstances that the impact upon them. So thanks for highlighting that as part of the information. And can I bring you in?
Thank you. Just a little question. I think that the benchmarking information is really useful. Gives us an idea of what the ranges are. The particular chart that the particular data I was looking at was on page 268, the home care costs per hour for people aged 65 or over, because there does seem to be a huge variation in home care costs per hour, and I'm assuming that there are reasons for that, and Falkirk does appear to be quite high by comparison with other local authorities. Now that might be a good thing, it might be a bad thing. I'm not being judgmental.
Oh, sorry.
Callum, if you want to come in first, and then Patricia will add anything to it.
That's okay. Yeah, just on that specific point there about that variation. So, you know, one of the benefits of the framework is that ability to compare ourselves to other areas, but it also comes with, you know, some challenges, and we do need to be cautious at times as well. The variation in that particular indicator is so great that I suspect that we're for some areas we're not comparing apples with apples. So we may want to proceed with a bit of caution with our interpretation with that. However, that said, I think we should try and, you know, learn what we can, and even if some areas are comparable, then that is a helpful thing in itself. So, I think earlier on in the agenda there was an item about the care and support at home contract strategy group. You know, and I'm supporting that group with some data and analysis to help them with their decision making. So we've shared the output with them for their comment and consideration, and see if there's anything we can learn from that.
That would be useful, and I think you're probably right, given the extent of the variation, that what's being counted in that cost is maybe not the same in every local authority, but it is certainly worth further investigation.
Yeah.
That's fine. It's Carol.
Caroline put a comment in the chat. I don't know if she wants to speak.
Caroline, I don't know if you want to come in. Oh, yeah, I'm looking for you on the screen.
No, I didn't realise that it was not. I shouldn't put it in the chat. It was just on the absence thing. I was just commenting that short-term absence can be quite significant as well in terms of conditions that people have, which I can't remember what exactly I put in the chat, but I was just thinking people might have a condition which may be a disability that means that they're very regularly off work, so it's going to be a long ongoing thing, whilst not long-term absence was really all I was commenting on. Thanks.
Thanks, Caroline. Are there any other questions? I've got a quick question, Callum, around and I equally found that the benchmarking really interesting and really helpful. There's a couple of questions around 269 and 269 and there we are. 273 and kind of 271, the question of self-directed support and managed personalised budgets, that seems quite a difference, and the talking about a figure that's halved, and I suppose that then there's sort of corresponding drops around agreeing about having a say in your help, care and support, and about the impact on improving and maintaining quality of life. And I suppose I'm not quite sure who this question is for, because I know that there's a self-directed support improvement plan seeking to kind of reinvigorate self-directed support nationally, and I suppose that's some sort of I guess assurance of what we are doing locally in relation to that.
I'll maybe come in on the data if that's okay. So, you know, as you've rightly pointed out, that was quite a stark decrease that's made us ask some questions internally. So we've set up a small group that wants to look at the quality of our data a little bit closer. So we're going to have our initial meeting next week, but you know, one of the early questions that we'll have is, you know, has our move to a new financial system, Contract, around that period, has that impacted some of the data around that? And also, I think there may be a suspicion that we could be underreporting on SDS option 2. So we really need to take a deeper dive into our own data and understand that a little bit better. And as we do that, I can certainly report back on progress in that area.
Thank you. Are there any other comments or questions? Well, thank you very much, and are we happy to agree the recommendations?
Agree.
Okay.
Agree.
Okay, I'll move us now on to the IJB governance report and pass over to Dave.
Thank you very much, Chair. This report updates on a range of governance matters that are relevant to the board. So first and foremost, the Clinical and Care Governance Committee is required to review its terms of reference annually, and also to note the chairing arrangements and membership of the committee. This was last done in August 2022. There's also ongoing work to review the Clinical and Care Governance Framework, and the committee terms of reference will be completed alongside the review of the integration scheme and due diligence work on the transfer of PAN Forth Valley NHS services to Falkirk HSCP and Clacton Stirling HSCP. Once that work to review the framework in terms of reference has concluded, any amendments will be presented to the board for consideration. In the meantime, there is a requirement to review the terms of reference on an annual basis pending the conclusion of this work. The committee will consider its chairing arrangements, or it has considered its chairing arrangements at its meeting on the 22nd of September, and the terms of reference remain unchanged currently and are attached to Appendix 1 for approval. So Councillor Anne Hannah will continue as chair of the committee, and Stephen McAllister will continue as vice chair respectively. As you'll be aware, through a series of updates to the board over the past year, we have received a letter from the HRC in June 2022 highlighting failings to comply with some of the Scottish specific duties in relation to the public sector equality duty. Since then, I'm pleased to report that the board has embarked on a significant programme of improvement work to ensure compliance with the public sector equality duty. And this has included the publication of Equality Outcomes and Mainstream Report for 2022 to 23, and the agreement that all reports are subject to an equality and poverty impact assessment. One-to-one EPIA support has been provided, and the publication has increased on the number of EPIAs published on the HSCP website has increased. All IGBs across Scotland were required to submit evidence of their improvement work to the Equality and Human Rights Commission by the 31st of March this year. And I'm pleased to say that we have received written confirmation from the Equality and Human Rights Commission on the 18th of August to confirm that Falkirk IJB is now compliant with our obligations under the Scottish specific duties. And I think that's testament to the hard work of officers and also the engagement of colleagues in that improvement work. Whilst the board is considered compliant, work remains ongoing to continuously improve our practice and ensure that we now take a proactive approach to equalities. As some of you will be aware, a motion was recently agreed by Falkirk Council at its meeting in June to add care experienced as a protected characteristic into the Council's Equality and Poverty Impact Assessment. This is a tool that we use for IGB reports, and this is where the term care experience is used to describe anyone who is currently or has been in the care system. Officers are going to consider the implications of this agreement for the IGB, and we're going to prepare a report and bring that to a future meeting. Back to equality outcomes, so work is ongoing to develop a new set of outcomes, and we are due to publish these by April 24. 2 outcomes are under development, and engagement is ongoing with local groups to define the draft wording of the outcomes. We have had a series of pre-engagement workshops back in May, June and July, and we last week launched our phase 1 6-week public consultation. The consultation is hosted online via the Citizen Lab, which is the Falkirk Council engagement tool, and that will close at the end of October. Alongside that, we are going to do a significant amount of work engaging with stakeholder groups and communities, and we've been having lots of face-to-face discussions with them. We'll bring a draft equality outcomes report, which will be presented to the SLT in November of this year, and then we'll have a draft initial report brought to the IGIB in December of this year. That will be published online so that the public can review this and add any comments, and then we'll kick off a phase 2 consultation in January and February of 2024 before bringing a final report to the board in March 2024. In relation to the review of the integration scheme, work is progressing with Falkirk Council and NHS Forth Valley in conjunction with Clarkson Stirling, IGIB Chief Officer, and senior managers to review the integration scheme. This has been supported by the Scottish Government as part of the escalation support being provided to NHS Forth Valley. Work to review the scheme will include a review of the standing orders and reviews of the Clinical and Care Governance Framework, as previously discussed, and the Clinical and Care Governance Committee terms of reference, respectively. A timetable for the completion of the review of the integration scheme requires agreement. And as we'll probably all be aware, following the announcement that Cathy Cowan has retired from her role, Amanda Croft has been appointed as Interim Chief Executive of NHS Forth Valley. So just returning to the recommendations before passing back to you, Chair. We're asking the board to approve the Chair and Vice Chair arrangements of the Clinical and Care Governance Committee, approve the terms of reference of the Clinical and Care Governance Committee on an interim basis. Note that the Equality and Human Rights Commission have confirmed that Falkirk IGB is compliant with the public sector equality duty. Note the draft equality outcomes in consultation period. Note the update on work to review the integration scheme. And note the appointment of Amanda Croft as Interim Chief Executive of NHS Forth Valley. Thank you, Chair.
Thank you. Do we have any comments or questions? There's none. In that case, are we happy to approve the Chair and Vice Chair arrangements for Clinical and Care Governance? Just nod your head. Great. And approve the terms of reference for that committee as well. And the rest is just for noting. So thank you very much, Dave. Our next item is the annual assurance statements. I'll pass back over to Steve.
Yes, thank you, Chair. This report presents the 2022-23 annual assurance statements for the Audit Committee, Clinical and Care Governance Committee and Joint Staff Forum, respectively. I'm not going to say too much about these. These are the 4th annual assurance statements prepared by the committees in the forum in response to a recommendation arising from an internal audit report. The annual assurance statements, which are attached to this report, will set out the attendance, meeting dates and business of the committees and forum during the financial year from April 2022 to March 2023, and this will provide assurance to the IGIB that they have discharged their duties during that financial year. And the board has been asked to consider and comment on the annual assurance statements attached as an appendix to the report. Thank you.
Thank you. Can I open that up for any comments or questions? There are none, so happy to agree their recommendations, although they're just a consider and comment. Thank you. I'll move us on to our next report, which is the Information Governance Assurance Report, and I think, is it Sarah or Linda or Sandy? I've got 3 people.
It's Linda.
Thank you, Linda.
So, good morning. I'm Linda Allen, Data Protection Manager for NHS Forth Valley. My colleague Sandy Blair, IG Project Manager, and I are here to represent Sarah Hughes-Jones, NHS Forth Valley's Head of Information Governance and the Integrated Joint Board's Data Protection Officer, to present the assurance report regarding the IGIB's information governance activities and compliance. This assessment is specific to the records and information belonging to the IGIB. As highlighted in previous reports, the IGIB has limited exposure from an information governance perspective because it processes limited records and information in its own right. The majority of processing is undertaken by either the Health Board or the local authority, which have their own systems in place to manage their statutory compliance. So as a rule, the IGIB is supported by the processes which are in place by the partner organisations and can consequently be reasonably assured that the appropriate arrangements are in place. As reflected in this report, the current arrangements in place to meet the requirements under the Data Protection and Records Management legislation are working well, and there are no areas of concerns to highlight at this time.